will see a significant connection between the eye between the eye and the entire body. So go to the next slide kindly. The next slide. Thank you. So we'll first look at the structure of the uvea. And so the uvea is a term that is given to basically three tissues of the eye, where we have the choroid posteriorly. We'll look at the structure, just some slides to come. Then we'll have what we call the ciliary body, and we have the iris. When you look at the structure of the eye anatomically, we have some three tunics or covers of the eye that covers the ocular contents, where we have the sclera without, then we have the uvea, then we have the retina. And so the uvea basically is a tissue that supplies the internal organs of the eye, or the internal tissue of the eye, with the blood. And so anteriorly we have the ciliary body, we have this iris, then posteriorly we have the choroid. I go to the next slide. And so today I want to dwell so much upon anterior uveitis. Then if we'll have time, maybe in the future, we'll see posterior uveitis, because uveitis is a very comprehensive and a wide topic that we cannot unleash it completely in this one presentation. And so the iris is a diaphragm. That means that term, for the sake of understanding, that is suspended or found between the lens and the cornea. Its basic function in that region is to regulate the amount of light that reaches the retina for perception of the visual the visual world. Ciliary body is a continuation of the choroid, and it has muscles which controls the biological process of accommodation, and equally opening the channels of the trabecular meshwork, which always helps in regulating the amount of aqueous humor in the anterior chamber. And go to the next slide so that you can see. Slide number 5. Thank you so much. So we can see there. So on my right hand side, we have the anatomy of the eye. Then we have a cross section anatomy of the eye. So we can see that in between the iris, we have a dark aperture that we call the pupil. Then we have the iris surrounding it. Then when you go to my left hand side, you'll see that peripherally, we have the ciliary body. Then we have the choroid as a posterior continuation, a posterior portion of the uveal structure. You can go to the next slide. Yeah, so we can see that we have the lens posteriorly, then we have the cornea anteriorly, then we have the iris resting on the anterior aspect of the lens. Then we have the ciliary body, some zones that are attaching or are holding the lens in position. Go to the next slide for the sake of expounding this anatomy. Yes, so we can see a slit. Just go to the last, to the preceding slide. Slide number 7. This is an image of the eye, particularly the pupil and the iris from a slit lamp. And we can see we have a dark aperture in between, which we call the pupil. Then we have some, let me call them serrated margins or serrated portion, what we call the collarate of the iris. In fact, that's the thickest portion of the iris. Then we have the root of the iris peripherally. Yeah, so as we continue now see, a cross section of the iris, and you see histologically the structures that make up the iris. You can go to the next slide now. Yes. So when we begin from within, so we have the iris structure, and we have histologically what makes up the iris. So we have the anterior border of the iris, which is just, let me say, a condensation of the stroma of the iris. Then we have the layers of muscles. This is the striated muscle, sphincter muscle. Then we have the anterior iris epithelium, which is non-pigmented, and then the posterior pigmented layer. So as you come towards the pupil, the anterior epithelium of the iris will, let me say, it does not come to the anterior part of the pupil. That's why the pupillary border always appears to be darker when you see through the slit lamp. You can go to the next slide. Yes. So we can see that the iris is resting upon the surface of the lens. Then we can see the choroid. Then we have those zones attaching to the lens. Then we have some muscles in the choroid. Oh, sorry, the ciliary body. The ciliary body equally contains muscles which will control the process of accommodation, or when the eye wants to focus an image which has come close, it must increase the power of the crystalline lens. So the choroid has muscles, we call them the ciliary muscles. The ciliary body contains muscles which will help to control this focusing power of the lens in its contraction and relaxation. But today we're not look into that so much. We want to look at this stuff, or at this anatomical structure, as a means of supplying blood into the internal organs of the eye. You can now go to the next slide. Yes, thank you so much now for this slide. Now I want to focus here so much. So in this slide, towards my left hand side, we have the cornea. Then we have the iris resting upon the surface of the lens. Then, as you go, let me say, as you go clearly in that structure, you'll see a place that is labeled the major arterial circle. So as blood vessels come from the, let me say, from the ophthalmic artery, you'll see it in the next slide. So as they come from the ophthalmic artery, we have some branches. We have what we call the ciliary arteries. We have the posterior ciliary arteries, and there are two divisions. We have the long division and the short division. So the short division will supply the optic nerve. The long division will travel, and then they'll come and travel through the choroid into the ciliary body. So in the ciliary body, they will come and join together in a circular manner, what we call anastomosis. Then they'll form what we call it's called the major arterial circle. Then they will get into the iris, deep into the iris. Then they'll come and join in a circular manner. Then they form what we call the minor arterial circle of the eye. And so we can see from that basic anatomy, let me not dwell upon that so much, that the choroid, the iris, and the ciliary body are adapted to supply blood into the eye. So their function is to provide nutrition into the eye through the blood supply system. We can go to the next slide. This is explaining now. So you can see we have the center of the retinal artery and the vein supplying the areas of the retina. Then you can call the short posterior ciliary artery and the long ones. So the long ones will travel and they'll come into the first into the apex of the ciliary body. They'll come the choroid, then they'll form a circular junction or a circular connection, which will now begin to supply blood into the choroid, and this will even help to form the nutrition, which will be drained as human to supply nutrition into the lens and into the some let me say some layers of the cornea. Then they will go deep. You can go to the next slide. The next slide. Yes. Then they'll go deep into the iris in an oblique fashion. Then at the apex of the iris, they'll form a circular connection, what we call the minor, let me say, it's called the minor arterial circle or the circulus arteriosus iridis minor. So they are adapted to supply blood into the eyes. Now, from that anatomy, I want us to consider something before I proceed. Of all the organs in the body, the eye has a very significant design because the eye has two tissues which are very clear, the cornea and the lens. Through the cornea and the lens, we can see the entire structure of this organ or the eyeball. And so we can see what's happening inside the eye through these two structures. And so I tend to think that as an optometrist, we should not just see the eye as a refractive structure, but we should see the eye as a real biological system that contains, let me say, contains in a miniature or in a miniature what the entire body contains. When I use, let me say, when I use the example of a house, we have a window, we have a door, and we have the entire body of the house. And so the eyes is like a window that you can peep to see what's happening in the body. Let me explain what I'm saying. This blood supply system of the eyes is like what? It's like the blood supply system of the body. And so when anything happens inside the body, the eyes can act as a reflection, an expression of what's happening inside the body. And so I want to see that through uveitis, we can learn that there is something maybe that is taking place in the body that is being expressed through the eye as a window to know what's happening in the body. Go to the next slide so that we can explain that deeply. The next slide. Thank you so much. And so we can see here, we have some, let me say, some cells or some abnormal structures in the anterior chamber of the eye. Let me explain that as we proceed. So we see that uveitis is a term used to label the inflammation of the uvea, because the word in medicine will mean inflammation of an organ in the body. So uveitis is the inflammation of the uvea. Today we are in anterior uveitis. So inflammation of either the iris, what we call iritis, or the ciliary body, what we call cyclitis, or both the iris and the ciliary body, what we call iridocyclitis. And so when we have inflammation in the body, we have some, let me say, some cardinal signs which will explain inflammation or which will express inflammation. So we always have what we call heat in the body. Then we have, I'll explain heat in the eyes. Then we have redness, we have swelling, and all of that stuff. And so in the eyes, when you have inflammation in the eyes, the first thing in the iris, you have blood vessels. These blood vessels, their endothelial cells are joined so close. But when there is inflammation, their, let me say, the junction will be compromised. And as a consequence, proteins will begin to come out of these cells into the eyes. Then these cells that we're seeing in the, let me say, in the anterior chamber of the eyes are lymphocytes or white blood cells. So they have come to this point because inflammation will trigger them to come into the point where we have a trauma or we have a problem. And so equally in the eyes, when problem in uveitis, they must come and they must be expressed. Then it is believed that due to the heat generated during inflammation of cells, and so in the eyes they'll move, and then they'll settle in the eyes, let me say, in the endothelial layer of the cornea in a base down triangle, what we call the ALS triangle. And so you can see that in the body, when you have inflammation, we'll have white blood cells coming to that place. We'll have redness. So we have like swelling of those blood vessels. We have a lot of blood coming to that place. Then we have heat in that place. And so equally, in the eyes, the same thing will happen. And so the eyes become an expression or a miniature that we can see using our diagnostic equipments of what is happening in the body. And so, let me say these statements, which I believe they are scientifically sound. When I go to the laboratory of the hospital, they'll take, let me say, they'll take my body chemicals, or equally, they'll take the pictures of my body to try to understand what's happening inside my body. And so, the eyes can act as a lab of the body. Why am I saying this? When someone has a condition inside the body, and this condition is affecting the blood supply system, or it's affecting the blood supply system, this it will affect equally the blood supply system of the eyes. And when the eyes are affected, they must express. And so I can get to understand that through what's happening in the eyes, I can get to understand that something is happening in the body. And so when I see something happening in the then the patient has some other signs. I can connect the two of them and make a diagnosis. But for the sake of confirming my diagnosis, I'll now reduce what the patient has to go to do in the lab, because at least in my mind, I have a structure of what may be happening in the body of the patient. You can go to the next slide so that you can see some other stuff. The next slide. Yeah, so the next slide, we now have what we call flares. So flares is just simply when so in the iris and in the ciliary body, we have what we call the blood aqueous barrier. But when it's interfered with, so proteins will begin to come outside the blood vessels and settle into the anterior chamber. And so when you shine a parallelepiped streak of the slit lamp, so you will see that between the cornea and the surface of the iris, we have reflections. Normally, it should be very dark. You not see this light because they are archaea. They are cells in the they are proteins in the anterior chamber. So they'll begin to reflect the light. So you can see that there is something happening in the anterior chamber. Okay, but flares are not an indication of inflammation, because maybe it's just interference of one blood vessel, maybe due to trauma, which is not that significant, but they add up to cause uveitis. If you have flares and some other stuff, you can continue. The next slide. Yes, equally. So when you have uveitis, so you have blood cells coming, especially white blood cells coming into the eye, and because the surface of blood vessels have been interfered with, so you'll have clotting factors coming into the surface of the iris and the surface of the ciliary body. And as a result, they'll form a sticky substance. So this substance will now begin to form attachment sites between either the lens posteriorly or the cornea anteriorly. And so when they come and attach to the lens, let me say they attach to the entire circumference of the lens, they'll now block the aqueous humor from coming from the posterior surface into the anterior surface to be drained outside the eyes. And this can cause what we call pupillary block glaucoma, very big and dangerous complication of uveitis. Then equally, as I continue that, when someone has uveitis for a long time, this will interfere with the formation of aqueous humor. And this will reduce the amount of the aqueous humor in the eyeball. And this can cause what we call hypotony. And if it persists for a long time, it can cause what we call phthisis bulbi, or a shrunken eyeball. And so we see that we have a paradox here of uveitis. It can either cause hypertony or hypotony, depending on the persistence of uveitis and the attention or the medical attention of the optometrist, ophthalmologist, or any eye care practitioner. You can go to the next slide. The next slide. Yeah, so this is what I was explaining. So we have posteriorly, you can see the inferior iris. So we have it touching the surface of the lens, and this will now cause blockage of aqueous humor from coming outside the posterior surface, let me say the posterior anterior chamber to the anterior side, and now it cannot be drained. Then you can see serially the iris is touching the angle, let me say the cornea. And so the angle where aqueous should be drained with is equally blocked. So it can equally cause blockage due to blocking of the trabecular meshwork. And so this is a very bad complication. And I see this complication does not only cause glaucoma, but if it persists for a long time, it will now begin to cause scars in the cornea. And this scars will prevent, or it will reduce the amount of light that can come from the visual world, and this will interfere with the visual acuity of the patient. And then equally posteriorly, because the iris, the first thing, we have inflammatory cells inside the anterior chamber. Then the lens, because of that inflammation, is not getting a good supply of nutrition and equally other significant requirements. And so because of this, the capsule of the lens, especially the anterior capsule of the lens, will now begin to harden. And this can cause what we call the anterior capsular cataract. And because the iris is touching the anterior surface of the lens, it will equally cause, and this will cause cataract. I will see as we proceed that some patients, the first sign of uveitis, maybe it's a chronic onset, it does not have any pain, but the patient will now begin to see something like white, let me say a white color in the pupil. That's because of this complication of uveitis, where we have the iris touching the lens and equal lack of supply of nutrition to the lens, causing cataract. So it's a very bad complication of uveitis. We can proceed to the next slide. The next. Thank you so much. Preceding slide. I think I missed the slide. So you can go to the preceding slide. The preceding slide, slide number 16. Oh, thank you so much. And so as we have seen, uveitis itself is inflammation of the uvea. And we've understood that uvea is the blood supply system of the eye. And so if the blood supply system of the eye is interfered with, it must express that interference. You've seen their flares. We've seen posterior and anterior synechia. We've seen cells in the anterior chamber. And the vehicle sometimes can cause cataract. And this process can be an expression of what's happening in the body. So we want to see the connection that lies between the body and the eyes. You see, we should not treat the eyes as an independent structure, because the eyes lies inside the body. And because the eye is a biological system, it can equally become a window or a camera that you can use to see what's happening inside the body. For example, if someone has diabetes, you can see the progress of diabetes inside the body using what's happening in the eyes. And so the eyes itself, when properly understood, not only as a refractive structure, but as a biological system, can act as a very significant method of optometrists making themselves relevant in the clinical setup. We should not just see ourselves as a refractionist, but we should study the eyes to understand it deeply so that it can help us to give meaningful information to our patients and to equally give meaningful information to the patient's physician if they may lack information because they may not understand it as we understand, because we have a very deep understanding of the eye based on the length of time that we used to study the eye for an entire 4 or 5 years, depending on the country that you are studying. And so we want to see the connection between this anterior uveitis and the body conditions. So the first body condition that I want us to see is rheumatoid arthritis. And so rheumatoid arthritis is an autoimmune condition where we have what we call a rheumatoid factor or antigen inside the bloodstream. Then it causes an antibody antigen reaction. Then this will affect especially the joints of the body. Someone will have weakness of the joints, and sometimes it can equally affect the heart of the patient, and because sometimes the lung of the patient. Then this reaction is in the bloodstream. It may travel, or it will travel and go into the eyes. When it goes into the eyes, it will elicit, or it will cause an inflammatory reaction. And so someone will have uveitis. So someone comes into the clinic, you see uveitis, and you see rheumatoid arthritis, especially if it's in a, let me say, in a juvenile patient or in a pediatric patient or patient that are, let me say, children, it always has a chronic onset. I mean, this one is a chronic onset. It does not come suddenly. So there is no, let me say, there is no a painful, a sudden onset of pain in the eyes. There is no photophobia suddenly. So it comes progressively and gradually. But because of that gradual progressive onset of uveitis, the patient does not realize that there is something happening in the eyes. So because of this, it begins to damage the eye structure. So the patient may come to the hospital when he has even the cataract already developed. Then he now begin to inquire of his, let me say, his body condition or the general body health. You'll hear that he's telling that he has some stiffness in the joints and equal some pain in the back maybe and in the knees. And so if you see in the eyes, you have signs of uveitis. Then in the body, we have signs of arthritis. As an optometrist, because you know the connection that lies between the eyes and the body, you can now take these two information and join them, and then you can now make a diagnosis and only send this pen to the lab for a specific test in order for you to confirm or to establish confidence in what you've diagnosed based on your clinical knowledge. And so you see that even rheumatoid arthritis can be expressed into the eyes. And so the eyes become a window that you peek in to see what's happening inside the body. So in rheumatoid arthritis, this uveitis is always chronic, and then it's always non-granulomatous. Let me explain that. I failed to explain that initially. So you always have what we call granulomatous and non-granulomatous inflammation in the body. So granulomatous will mean that the cells involved in this uveitis, most of them are those cells which always secrete granules. And then when you see the cells in the eyes, these cells are big compared to the ones that cause non-granulomatous inflammation. Then they are equally, let me say, they are brown in color and they are crenated. And then when you see the eyes itself, in the iris, you will see some nodules, some swelling, some lumps. We call them Busaka nodules. Then in the margin of the pupil, the iris will equally have some nodules or some lumps. We call them Pope nodules. And so these nodules, when you see them, it's you have the capacity to see the trabecular measure. You'll see equally some nodules, what we call Berlin nodules, which will always block the drainage channel of the eyes. And so when you see those signs, connect them with what's happening in the body, at least you have a structure of making a very good diagnosis. Let us go to the second condition, what we call ankylosing spondylitis. So it's just simply, so we have bones that protect your spinal cord. So we call them the vertebral column. So when there's inflammation between their joints, it will destroy their cartilage, then these bones will fuse together. Then this patient will now have what we call, the back will be bent. But the cause of this condition is, we call, it's an antigen which the body perceives as something foreign, what we call HLA-B27 antigen in the body. And because this antigen is found in the bloodstream, it will equally go and affect the eyes. And so equally in the eyes, you'll see signs of inflammation. We'll have scleritis, we'll have conjunctivitis maybe. But the most frequent expression of this condition is uveitis. And so when you have uveitis in the eyes, there's always it's always chronic onset, then it's always non-granulomatous, then it's always unilateral and alternating. Maybe in one eye this time, then the other eye the other time. So when you have
It's
both
just
that expression in the eyes, then equally you have
just
someone having learning of call it
sorry,
yes.
Daniel, for interrupting. The link, okay, the meeting will end in the next less than 1 minute, but then people can rejoin using the same link immediately. Immediately it cuts, you just rejoin using the same link. You can continue.
Thank you. So let me just explain this condition very fast, then we'll rejoin after I